Welcome everybody. Nice to see you here. So Josh Mersky is here. He's going to talk about this is several studies. He's happy to take that. I'm not going to keep time, but go ahead.
Dynamite. Thanks so much, Michael. Hey, thanks so much, everyone, for being here today. How are you doing? Good. All right, good. Glad to hear it. It really is an honor to be with you all here today. Back at my alma mater, I was a doctoral student back in the day in the School of Social Welfare, so I'm really glad to be back here. So yeah, quick housekeeping before I get started. Please feel free to interject or ask questions as I move forward. I will be coming up for air periodically as I move forward. I do tend to proceed at a brisk pace, so don't hesitate to slow me down. I won't mind. All right, so let's get started. So yeah, I do a lot of research on adverse childhood experiences, the prevalence, consequences of adverse childhood experiences, and I'm going to today try to synthesize some of my interests while at the same time trying to build some bridges with many of your interests in poverty. So we'll see how we do. Just some funding acknowledgments real quick. Some of the folks who have helped to fund some of the work I'm going to be presenting today, as well as an acknowledgement that what I'm going to be presenting today are my words, and I represent my perspectives alone. An outline. What are we going to be doing today? First off, I know some, if not all of you all, are familiar with this concept of adverse childhood experiences, but there may be varying levels of knowledge in the room. So I'm going to do a little level setting exercise, just do a brief ACEs 101 kind of thing to get us all on the same page. Then I'm going to be talking about some ways that people in the field, including myself, are pursuing different lines of second generation ACE research to kind of push the envelope in this area. And one of those areas which we'll end up on is strategies that we might employ, policies, programs, etc., to either prevent ACEs or mitigate their effects. Does that sound good? Sound good? Sounds great. Okay, so the Adverse Childhood Experiences Study, you are probably familiar with this. Major public health study, one of the most prominent studies, I would argue, in that field over the last generation. Launched in the mid-1990s. Vince Flitti, Rob Anda were the principal investigators. It was launched by the CDC and Kaiser Permanente Health Insurance with the big idea. They had these are medical doctors, and they had observed over many years that the patients that they had seen who were presenting with health concerns often reported adversities that they had experienced in childhood. And so they started running this hypothesis that, oh, maybe there's some kind of connection between chronic obstructive pulmonary disorder or heart disease or hypertension or what have you, and these bad things that occur in childhood. And so what they did is they assembled some data. They ended up over 2 different waves, getting a sample over 17,000 patients in San Diego, California. They were able to then match some of the survey data that they gathered from these folks, where they reported some of their childhood adversities with some of their health records and look at their long-term health outcomes. Important note, the average age of the sample was 57 years of age, which is advantageous when you want to look at certain kinds of health outcomes that don't typically manifest or aren't observable earlier on in the life course. This was also a more educated sample with private health insurance, which limits its generalizability to some degree. What kinds of adversities did they look at? These are the terrible 10 that have been pretty much studied since the original ACE study was launched. They studied 5 different forms of child abuse and neglect: physical, sexual, and emotional abuse, as well as physical and emotional neglect. And they also studied 5 different forms of what they called household dysfunction that correlate with child abuse and neglect. Things like growing up in a household where your caregiver abused substances or had a mental health concern, where there was domestic violence, where one of your parents was involved in the criminal legal system, and divorce and separation. Can we agree momentarily as a group, before I proceed, that if in the interest of promoting child development and flourishing over the life course, that these are experiences best to be avoided? Can we all agree that these are bad things? In other words, relatively speaking. Okay, thank you all. You're too kind. So that sets me up nicely to think about some things we're going to be talking about later. What do we know about ACEs? These 10 very bad things. Number one, ACEs are quite common. These are not rare events in our society. They're actually quite common events, and not just in the US, but also worldwide. If you look at epidemiological studies, they vary, of course, but overall, roughly about 60% of adults worldwide report having experienced at least one of those 10 bad things. Secondly, as I already alluded to, ACEs are correlated. They're interrelated. They are not randomly distributed in the population. They tend to cluster within families, within communities, such that if you experience one type of ACE, that puts you at an elevated risk of other types of ACEs. For example, child abuse and neglect is not randomly distributed. We know that it's more likely to occur in families where there are substances being used in the household. Just an obvious example. That's a really important point, this interrelationship, because ACEs are also highly consequential, but they're consequential in a specific way, such that the more ACEs that you've been exposed to, the greater your likelihood of a wide variety of poor life course outcomes, not just poor health outcomes, but also poor mental health outcomes, lower status attainments, etc. Lastly, ACEs are costly. In addition to the individual costs, individual consequences of ACEs, they are also associated with major costs to society. One estimate indicated that just health-related costs alone, they found that they could tie that to that the costs were $14 trillion per year in things associated with things like disability adjusted life years. So increased risk of morbidity, mortality, healthcare costs. They pegged it at 14 trillion per year. Take that for what it's worth, economists. I'm not gonna. It wasn't my study. Okay, so these consequences that we're talking about, again, I mentioned the fact that they're associated with poor outcomes in a specific way. What I want to show you now are a few findings from the seminal ACE study where they demonstrated this dose response effect, right? So this is just looking at smoking behaviors. What you can see from this slide is that, let's take early smoking, for example, that individuals who reported 0 in this Kaiser Permanente study, about 4% of those individuals who were exposed to 0 ACEs reported that they had started smoking by the age of 14. As compared to folks who reported having experienced 4 or more of those childhood adversities, about 12.3% of those folks reported starting early smoking. In other words, ACEs were associated with a threefold risk of early smoking if you experienced 4 or more as compared to 0. But then you can also see in between, there's a gradient, right? It's not just all the risk is at the tail end of the distribution. There's a ladder-like sequence of effects that we're observing. Please, in the back.
Give us a sense, just like what the kind of distribution across the population is in these buckets, like what percent of the 0 bucket versus the 4 or more bucket?
That's a great question. So we already know this. We already know the 1. So if it's just 1 or more, you're looking at about 60% or so.
The question, I couldn't hear it.
Yeah, sure. So it's what is sort of like the relative prevalence in each one of these bars? Like what percentage of the population, say, has 4 or more ACEs? I'll just focus on that one. Estimates are about roughly around 22% of the US population has about 4 or more ACEs, right? But then it's going to vary by sample, of course, or what have you, but that's roughly about where it is. Is that okay? All right, dynamite. So this is smoking, right? Okay, that's one outcome. How about obesity? Second verse, same as the first. You see this dose response ladder-like sequence such that the more ACEs that you reported, the greater your risk of being obese in adulthood. More than a 2-fold risk if you had 4 more ACEs as compared to 0 ACEs. How about heart disease? Again, an outcome that doesn't manifest typically in observable ways until well into midlife. Again, we see a similar, not quite the same distribution, but still a dose response effect such that by the time you get to the tail end of the distribution, these are expressed in odds ratios. If you experienced 7 or 8 ACEs, you were at more than a 3-fold risk of having heart disease than if you had experienced 0 ACEs, right? Now, these are associations, right? They're just associations. One of the major limitations in this area of research is when we want to gather data about ACEs, we typically do so retrospectively, right? We ask people to experience it when you're in childhood. There's a lot of limitations to that. And so a natural skeptic, like everyone in this room, would be like, well, these are just correlations. Why should we have any faith that this is anything causal underneath the surface? Don't know, but there's a couple things to pay attention to. Number one, again, that dose response sequence, right? These kinds of patterns, that is a hallmark of causality, that you'll see an association, that the strength of the dose should be associated with the strength of response. That's one signal. Another signal has to do with the mechanisms of effect. We have some very plausible mechanisms of effect that we think can link ACEs to later life outcomes. And you see that expressed in the outcomes that I selected: smoking, obesity, heart disease. What's the story here? Smoking, obesity, heart disease. What do they have to do with each other? Okay, stress, and they lead to each other, right? What are the major environmental causes of heart disease? Smoking and obesity. And which comes first, typically speaking? Smoking and obesity leads to heart disease. So what we have is potentially a chain of stress-related causal mechanisms beginning in early childhood, laying a weak foundation, developmentally speaking, such that ACEs, and many studies have demonstrated this, have been linked to disrupted neurodevelopment, has implications for brain development, stress response systems, and dysregulation. It leads to all kinds of cognitive impairments, socio-emotional dysfunction, as well as then later risk behaviors. These early deficits that emerge in part as a result of exposure to adversity then lead to an increased risk of health risk behaviors like poor eating habits, risky behaviors such as drinking, drug use, risky sexual behaviors, risky driving behaviors, all the things that can lead to an increased risk of dysfunction, disease, morbidity, mortality, and then ultimately, Does it make sense? So this is the original ACE pyramid. This is from the CDC, and this is their model of, in a very general sense, of how adverse experiences might lead to those later life outcomes that we've looked at already. Okay, so let's fast forward a bit, if we could, and start thinking about some other ways that we might advance beyond where much of the ACE research has been to date. So one of the things that I'm going to be talking about today is some of the work that I've been doing and many others in the field, thinking about how to expand the ACE framework. You'll already agreed, you can't take it back, that those 10 things were bad, right? But are those the only bad things that happen to children? Are there other types of experiences that are not captured in the original ACE framework that we should also be considering? Secondly, exploring disparities. ACEs are widely distributed in the population, but they are not equally distributed in their population, and their burden is not equally distributed. We'll be considering some interesting research along those lines, things I find interesting. Lastly, again, identifying prevention and intervention strategies, the so what of things. What can we do? What kind of policies, programs, what levers can we pull to hopefully, ideally, prevent ACEs from occurring, but also to mitigate their effects? So, expanding the ACE framework. I've done some work in this area. Back in 2014, I developed with some of my colleagues an expanded ACE assessment that incorporated not only the original 10 ACEs that we all agreed are not good things, but then we added in some other kinds of adversities that we thought shared similarities, shared commonalities with those original ACEs. For example, frequent financial problems, food insecurity, and homelessness. I'm not just doing this to pander to this audience. This is literally in the measure. The idea here being that these things are often interrelated. They're often correlated with those other ACEs. And in and of themselves, they have some of the similar mechanisms of effect. They undermine many of those developmental systems that we've already talked about with the original ACE framework. Oh, cool. In addition, we also added in measures of prolonged parental absence and parent-sibling death. Why prolonged parental absence? Well, in the original ACE study, they captured divorce and separation. important experience as a child of divorce. I can attest that it has negative consequences. That being said, one of the problems with a measure of divorce and separation is that it's predicated on marriage. And of course, many children grow up in households where their caregivers were not married. And you may, if you only ask about divorce or separation, you may be missing out on other similar kinds of salient experiences that can negatively impact children. Prolonged parental absence, we measure that. Parent-sibling death, I don't have time to get into the full story today. We did include this measure. It's not the most robust ACE indicator. If anyone's interested, I'm happy to talk about possible reasons why, but it's there. In addition, we added in measures of bullying and peer victimization. And the significant contribution here, in my estimation, is these items, unlike all of the original 10 ACEs, occur outside of the immediate home environment, right? So the bigger goal here, the big idea in mind that we had was we wanted to increase both the ecological validity as well as the cross-cultural validity of these ACE measures. Here's a couple of validation studies. And if you're interested in a copy of the measure, it's free open access measure. You can access it there. So let's look at some data. We've gathered data using this tool through what's called the Families and Children Thriving Study. This is a prospective longitudinal investigation of nearly 2,000 families in Wisconsin that received evidence-based perinatal home visiting services. I'll talk about perinatal home visiting in a little while. Suffice it to say, these services, as they're delivered in Wisconsin, typically target economically disadvantaged families where there's a pregnant person or a young child in the household. Just to illustrate the composition of our sample, roughly 2/3 of the sample is at or below 100%, or was at or below 100% of the federal poverty level. At enrollment, about 98% are at or below 200% of the federal poverty level. So this is an economically disadvantaged sample. I'm going to be showing quite a bit of findings from this study, so I hope you are grasping that now. I want to have in mind who these people are. This is compared to the general population, more economically disadvantaged, also more racially and ethnically diverse than you'll see in the Wisconsin population, also almost all female, reflecting the population served. Okay, so let's look at some data if we can. Let's look at the prevalence of ACEs. We've sort of already covered that ACEs are highly prevalent in the population. They're particularly prevalent among certain population subgroups, including this sample that I'm looking at. To illustrate, roughly 40% reported that they had been physically abused in childhood. More than a quarter of these women reported that they had been sexually abused. Roughly half indicated that they grew up in a household with a caregiver who abused substances. Well over a third grew up with a caregiver who had been incarcerated or in jail. That rate alone is 7 times the rate that they found in the original ACE study. Overall, 85% reported at least one ACE, significantly higher than what you'll see in the general population. Even more so, 45% reported 4 or more ACEs, which is twice the level or twice the rate, twice the prevalence that you'll see in the general population. And again, we're only asking about these 10 terrible things. There are other things that are best to be avoided. Here are some other indicators. 35% reported they grew up in a household with chronic family financial problems. 23% indicated that they had been homeless at some point in childhood. 18% reported experiencing food insecurity. Now, that's one way that we could expand the framework by incorporating additional types of childhood adversities. Now I want to talk about a second way that we might think about building upon the original ACE framework, not just by adding more childhood adversities, but extending the ACE framework into adulthood. My idea was, well, it worked so well in childhood, why not apply the same idea to adulthood? In my mind, one of the great contributions of the ACE framework is its integrative properties. It brought together disparate things that are often studied separately into one tight, parsimonious, and powerful package. could we accomplish the same thing in adulthood? So I developed this tool called the Adult Experiences Survey, and we piloted it in a couple different studies. I'm going to share a little bit today. So we're measuring these things that I call adverse adult experiences. First set are experiences associated at some point in adulthood with a spouse or partner. My theory being that some of our most powerful experiences in life, not just in childhood, but also in adulthood, are interpersonal in nature, are associated with our closest relationships. And so this in some ways is analogous or is parallel to those indicators of child maltreatment in terms of what I'm trying to accomplish conceptually. So we asked folks, have you ever had a spouse or a partner who was physically or emotionally abusive to you? Those are actually separate items, but we combine them because they're so highly correlated in the sample. We also ask about sexual abuse by a partner or spouse, mental health problems. Did you ever have a partner who had AODA problems? And did you ever have a partner or spouse who was incarcerated or in jail? We also ask an array of socioeconomic kinds of adversities. So in addition to sexual abuse, we also ask about sexual assault. We ask about exposure to crime victimization, discrimination, homelessness, and frequent family financial problems. If you're interested, there's a reference and also a copy of the measure. Please, Michael.
So when people are asked as adults to think about their childhood, do you tell them when childhood stops? Like it's like before
Sure.
18 or
Yeah, literally, that's literally the lead in to the questions before the age of 18. Yeah, so we'll even like double down on it, like as a child before the age of 18, just to make sure it's like abundantly clear. But same thing in adulthood, like since the age of 18 as an adult.
Okay.
Yep, great question. But then there's all kinds of complications with memory, like when did things occur? Yeah, great question. So here's some prevalence data, again, from the FACT study that I mentioned to you before. Again, economically disadvantaged sample of women here in Wisconsin. Highlight a couple that I think are interesting, maybe interesting to folks in this audience. Half of these women reported that at some point they had had a partner or spouse who was incarcerated or in jail. Well over a third, since they turned the age of 18, had been homeless at some point. You can see a lot of these prevalence rates are not, that's not good, they're too high. 86% reported experience at least one of these adverse adult experiences, very much similar to the prevalence rate we saw for ACEs in this sample. I want to point out something here. The mean age of these women, we're gathering these data, is 27 years of age. Why do I want to emphasize the age? Why is that important to take consideration when we're looking at these prevalence rates?
Only 9 years.
They're only 27 years of age. You know, they have hopefully a long road to go, but theoretically, at least, these rates should not drop. You're reporting lifetime experiences. Of course, memory changes, perception changes, what have you. But these rates can only go up theoretically. So as astronomical as these rates are, we may be looking at only part of the iceberg here. Yeah.
Was there a difference in looking, if you're segmenting by age, was there maybe one AAE that was more prevalent amongst older subjects versus younger? Was that kind of like, we haven't been able to do that yet?
So I haven't done it by actual experience yet. What I will say, and this is obvious, is that the older you were in the sample on average, the more adversities you reported. But I haven't done it by specific, and then that's from my pad. One moment. I'm taking ideas today by age. Thank you. Your name?
Blake.
Blake, that's a great question. I don't know the answer, but I want to look into it. So in addition to gathering these data through the FACT study, we also have been gathering data through a more recent study that we launched called the Strong and Stable Family Study. Time permitting, I'll be talking about this study a little bit more toward the end of the presentation. In brief, this is a longitudinal investigation of over 2,000 Wisconsin families with children, about a third of whom have received support from a family resource center in Wisconsin. If you haven't heard of what family resource centers are, by no means be embarrassed. They are a little known intervention or prevention model. I'll be talking about it later on. What are we looking at in terms of the demographics of the sample? You can see that they look a little bit different than the FACT study. A little bit older, 40 years of age on average, still predominantly female, in part reflecting who receives services, who identifies as a primary caregiver, and who's willing to complete a survey. But in terms of economic distribution, quite a bit different. You can see that roughly about there's the race and ethnicity, 81% white, pretty much spot on with population average in Wisconsin. About 40% had household incomes at or above 100,000 per year. So this is a very different sample. Looks a little bit more like the general Wisconsin population. I'm not saying it's a representative sample, but it looks a lot like it. What we find is that more than 75% of adults reported at least one of these adverse adult experiences. Not quite as high as we saw in the fact study, still pretty high, suggesting again that these are not rare experiences. These are actually disturbingly common experiences, for at least for predominantly female samples. Now, one of the other cool things I think that you can do, in addition to just documenting adult adversities and looking at their effects, is that if you start exploring adult adversities as well as adverse childhood experiences, you can begin to start thinking about life course adversity. You can start putting on your life course perspective to think about processes through which adversity accumulates over the lifespan. And this slide demonstrates in very basic terms how early childhood adversity is associated with adversity later in life. You see a very similar distribution to what we saw earlier when we were looking at health outcomes. On the x-axis, we have our number of ACEs, y-axis, percentage with 4 or more adverse adult experiences. And you can see that the more ACEs that someone reported, the more adverse adult experiences that they reported. 23.3% of folks who had 0 ACEs reported at least reported 4 or more adult adversities. That's compared to more than 2/3 of the folks with 4 or more ACEs, right? So this is probably pretty obvious, but I think it's important to demonstrate, right? Just like we know that a child who grows up in poverty is at an elevated risk of growing up to be an adult who is poor as compared to their more advantaged peers. The same thing is true of adversity, I think, right? That our environments tend to auto-correlate throughout the life course. And if you were exposed to lots of childhood adversity, that's gonna put you at risk of ongoing exposure to those similar kinds of experiences later in life. The CDC has started, I think, moving in this direction with their revised ACE pyramid. This is a little bit more elaborate than one I showed you before. The key difference is at the bottom. They've started integrating that we should take into consider social conditions and local context, as well as intergenerational and historical mechanisms of effect. I think that's really cool. I don't know, though, at least the way that they frame it, I don't know if it accomplishes exactly what I'm trying to accomplish. The way that they present it, they're looking at these as like the foundations or the conditions in which adverse childhood experiences emerge, at least if I take their flow chart literally. What I'm suggesting is the original ACE framework, those things that are above the ACE line, only consider individual level mechanisms of effect. It considers how you experience adversity, and then that has implications for your neurobiological development, your social, emotional, and cognitive development. I'm suggesting that we need to consider a parallel set of processes that are social and ecological in nature, such that early exposure to adversity, again, autocorrelates over the life course and puts you at an elevated risk of similar types of experiences later on. And that, in part, drives the effects of ACEs. Does that make sense? That's my argument. I'm sticking to it. Questions? This is where I come up for a break. Y'all are doing a great job of engaging already, so please.
You might be covering that.
You said you weren't going to talk.
I did say that, yeah. But I guess kind of similarly to what Blake asked earlier about age, I was also curious as to if there are disparities reported between women and men, and to what extent might it be because men tend to underreport some of what you identify?
It's a great question. I don't want to spoil it. I'm going to get into it a little bit. I don't want, but I want to respond on the question. It's a great one. So what I'll say in response is we do see differences between men and women in their self-reported rates of ACEs. That said, two caveats. Number one, there are differences, but they're not huge differences.
Okay.
They're modest differences. Number two, we again have to ask, what kinds of questions are we asking about, right? So when we ask questions about sexual abuse, which they do in the ACE surveys, naturally you're going to see huge differences between men and women in self-reported sexual abuse. Some would argue that men are particularly likely to underreport sexual abuse, and that could be a problem that you're alluding to. We also then have to ask, well, what are we missing? What are we missing that men might experience that we're not capturing? Like, for example, victimization of violence in a community, for example. Gun violence, things like that aren't being measured really for men. But great question. Is there another question? Please, Katie.
So I'm curious about the role of education.
Yeah.
So if you drop out of high school, your adulthood starts earlier and you're less likely to have like financial well-being, right? But that may be caused by ACEs as a child. So I'm like wondering if people that can stay in school longer, maybe finish high school, go to college, their adulthood starting later, and then it's like protective. It's kind of breaking this cycle, or
Yeah, for sure, right? I mean, it's a great hypothesis. What are again the mechanisms through which we can interrupt the transmission of life course adversity and potentially intergenerational adversity? There's no silver bullet, but education's a pretty good lever we could pull for sure. And I'll be looking in a little bit at some associations between ACEs and status attainments. So yeah, great question. Please, in the back.
So I was thinking about that cohort. Do you have any information on the non-responders to this, like the ACE survey, for example? And do you have any ideas about how non-response bias might be impacted?
Yeah, great question. So two different ways. So there's item missingness and case missingness, right? So I can say in brief, number one, case missingness, you were less likely to have completed the ACE survey as a whole. And by the way, these data were gathered actually by home visiting professionals, not by our survey team. If you were on average more disadvantaged. So there's probably, or maybe not fully representative of this broader sampling frame. Item missingness is probably a little bit more interesting to me. We do see, for example, this might not be surprising, highest rates of non-response to our item on sexual abuse, for example. And so then we have to do things to how to address that missingness. So I don't know if that answers your question.
Yeah, thank you.
Oh yeah, for sure. Next.
From the population, that it was families in Wisconsin. Do you know how many of the families were rural versus urban families?
Great question. I don't have the percentages for you per se, but so these data were gathered from families that receive services through what's called the Family Foundation's Home Visiting Program. This is a statewide, it's not truly statewide, but it's a broadly distributed program of agencies that deliver home visiting services, and they operate so there are around 30 some agencies that are captured that cover roughly around 40 some counties in Wisconsin. Of course, the distribution of families is not equal across those counties, but it does represent a pretty broad cross-section of families that are economically disadvantaged. So lots of rural, lots of urban, and proximal to suburban, if you will, if that makes sense. Yeah, great question. Please, back up.
So there's lots about being a victim of crime, but I'm just wondering, like, how does it impact if you're the perpetrator?
Yeah.
Like, unless you're a sociopath, you probably feel bad about it. Like how, I don't know if anybody's thought about that. Like what, you're an 18-year-old kid and you get in a fight and you hurt somebody.
Yeah.
A lot more than you intended. Like, how does that affect you?
Oh, yeah. Well, interesting question. I mean, in basic terms, number one, we do have good evidence to suggest that ACEs are linked to violence perpetration, not just violence victimization. But the second one to me, and I don't know if this was your intent, but it leads me to think about again those underlying processes, like why is it that ACEs are linked to violence perpetration? What does it do to your regulatory systems, your ability to self-regulate, et cetera, et cetera? What are also the environmental or contextual factors that ACEs are linked to down the road that increase your likelihood of engaging in that kind of behavior? So I don't know if that was a very good answer to an excellent question. Yeah. Blake, one more for you, and then we're going to move on. You get the last word.
Piggybacking off of that,
Yeah.
would you count a crime perpetration as an AAE? Because that's separate from incarceration, because not all crimes are, vast majority of crimes are not ending result in incarceration.
I mean, I guess it's who's the claimant. So are you saying that the person who experiences the
I would say both sides.
Okay.
Both the victim and the perpetrator
So
experienced an adverse adult effect.
it's certainly an adverse experience, event, or condition. That being said, I wouldn't want to incorporate it in like this measure, because I guess the underlying premise here is that these are things that are happening to you, not things that you're doing to others. That being said, it's worthy of consideration within the same realm of study. I think it's a fascinating question. All right, thank you. That's great. I'm going to move us along just in the interest of time. And I know, Michael, you're keeping an eye, right? Okay.
Good.
I got miles to go before we sleep here, folks. So I'm going to move us into some disparity stuff. So we know that ACEs are more likely to be reported by adults from certain population subgroups. None of this will be surprising to you. As we already discussed, they're more likely to be reported by women. They're more likely to be reported by low-income adults, by marginalized racial and ethnic groups, as well as sexual and gender minority adults. Probably not super surprising to anyone in this room. Just to reinforce some of the data that we looked at earlier in the FACT study, we were looking at women who were economically disadvantaged and relative to the general population, more likely to be associated with a marginalized racial and ethnic group. And so it's perhaps not surprising we saw such high rates of ACEs in that population. Now, the story gets a little bit more interesting, though, I think, once we dig in a little bit deeper and start thinking about those different identities, those different social categories, and the degree to which they're associated with disparities. So I've been doing some work sort of inspired by intersectionality. You all are all very familiar with intersectionality. This notion that if we only look at one social category at a time, if we only go from station to station, we may miss out on combinatory ways that these different types of categories, these different identities have multiplicative or additive or multiplicative effects on human experience. I've pursued this line of work in a quantitative way. There are others who would argue, and I'm sympathetic to these claims, that it's better pursued in a more qualitative way. That's totally cool. For the purpose of this exercise, I'm just going to share some quantitative findings where we've employed some more cutting edge intersectional approaches that you all may be familiar with. I don't know if you all are familiar with MIDA modeling, multivariate analysis of individual heterogeneity and discriminatory accuracy. So we just say MIDA. Basically, it's pretty cool because you can move beyond sort of fixed effects models where you go station to station and look at like one interaction term at a time, or worse yet, try to run some kind of three-way interaction or four-way interaction that are almost never interpretable. This enables you, it's a more flexible approach that enables you to look at those different types of categories at the same time to see if different kinds of outcomes are stratified along strata, different strata that are made up of a combination of those different categories. So I'm going to be looking at some findings here just real briefly where we've applied this to looking at disparities in the prevalence of ACEs. We've looked at it in different samples. I'm going to show you some estimates from the Ad Health study where we looked at economic status, sexual and gender minority status, gender status, and racial and ethnic status. Obvious limitations to the data we have available. The more you slice and dice the sample, you can't look at certain subgroups. But anyway, we have 3 different racial and ethnic groups represented, 2 different genders represented, 2 different sexual and gender minority groups represented, and 2 different economic statuses represented, poor and non-poor. What you can see is that when we divide our sample into these different combinations, right, you can see a really interesting distribution of ACEs in the population. First of all, starting on the right-hand side with the ACE score, you can see that non-poor, heterosexual white women reported the lowest ACEs, 1.28 ACEs out of these 10 ACEs on average, as compared to more than double that for non-heterosexual white women, 2.82 ACEs on average. So once we start combining these, you start seeing pretty significant stratification. But what you can also see is that these different categories are not contributing equally to the stratification. And not that this is a dominance analysis, but you see something akin to that, such that poverty is an incredibly strong stratifying variable for total exposure to ACEs, such that all strata, all of these different strata who reported that they were poor had higher ACE scores than all of the strata who were non-poor. And then next group over, you can actually see near perfect stratification by sexual gender minority status, right? Such that within the poor group, everyone who reported that they were non-heterosexual had higher ACE scores than those who said that they were heterosexual, right? And then you can see, once you move further over, it's a lot more mixed, a lot more variation by gender and race and ethnicity. So one bottom line of these findings is that income matters. ACEs are more prevalent, yes, among racial and ethnic minority groups overall. But there's some interesting findings once you get beneath the surface of the distribution of ACEs across racial and ethnic groups. Although ACEs are more prevalent among Black, Hispanic, American Indian populations, Alaska Native populations, we actually find, this has been shown now in multiple studies, that ACEs appear to be more prevalent among low-income white individuals than low-income Black and Hispanic individuals. So once you stratify by income and you only look at poor members of our society, that association reverses for whatever reason. And we see higher rates of ACEs reported by low-income white individuals and low-income Black and Hispanic individuals. If this is real, and again, it's been now found in 3 separate studies, actually 4, but any guesses why? Please.
Wouldn't it be because there's like a higher percent of like white people in the population, so it's just proportional to the population as a whole?
I don't know. I don't know if I would buy that at face, but let me think on it, because it is, like you said, you actually use that right word, proportionate, right? So I don't know. I'll think on it. Please, yeah.
Is there a lower percentage of low income?
No, I mean, it's the same kind of comment. I don't know if that's what I would go with necessarily. Here and here, please.
Could there be an urban-rural divide where the Hispanic and Black individuals live with more resources in cities around more people like them than maybe a rural white individual?
Fascinating. I don't know, but confounding factors, right? Maybe race is confounded with where you live, and maybe where you live is associated with your risk of experiencing those ACEs. I like the idea. Please.
I was wondering, maybe death might have a part to do in it. I don't know, but I'm thinking maybe the minorities, like if the ACEs, higher ACEs end in death, perhaps that's just leading to not getting measured as much.
Well, that's fascinating. Gosh, I'd never considered that. I'll think about it. Who else wants to give it a whirl? Please, Becca. And then is it Alvin? Is that...
Repeat what she said, someone back here.
Yeah, so sorry. I believe it was something to do with almost like, I don't know if selection effect is the right way to describe it, but the notion that, well, who is it that you're actually asking these questions of? If one group in the population is experiencing early mortality that might be tied to ACEs, you're not actually going to capture their ACEs accurately, you're going to get a distorted proportion of that group's ACEs because many of those individuals have died before you get the chance to measure it, which I think is a really cool hypothesis, by the way. Thank you, Becca, and then Alvin.
Discrimination, that people who are white are poor, perhaps more likely because of other dysfunction.
Oh,
People who are,
can we come back to that? So that there's something else going on within white households that we might need to take into consideration. I don't usually get that comment, but yeah, can we come back to that? And then Alvin, please.
We have a history of structural inequities.
Okay.
Know that structural inequities will predict where people live, how people live, resources, access to resources,
Yes.
access to health, education, mobility, and all of those things directly tied. Connection to the justice system, exposure to a number of different things that are directly tied.
Fantastic.
So it means that what we're seeing is not necessarily something, it's not a snapshot of today.
Yeah.
It's a shadow from 50 years ago.
So, and I'm going to actually fast forward, if you don't mind, to like some punchlines here, because I think you've really touched on where I wanted to land at the end, and then we'll work our way back to some other ideas. So for those of you who might not be able to hear, I'll do my best to summarize, but basically that there are certain structural inequities in society that are not, again, equally distributed by race and ethnicity, and that those structural inequities, if we don't take them into consideration, we may be missing out on an important part of this equation. I'm gonna just highlight 5 things, but I'm gonna start from the bottom because it is relevant to a speculative idea. I'm not saying this is the truth, but it's an interesting idea. It's one of differential assortment. So we have to think about, so in this equation, we're asking ourselves, well, what leads to ACEs? In this story, it's sort of reversing the equation a little bit. So let's start with the population itself. When we are looking at the association between ACEs and poverty, let's start with an assumption. I want to check if folks in here are on board with this idea. Is it possible that in the United States, that not just possible, do we somewhat agree that there are more ladders of economic opportunity in the US for white than most non-white populations? Is that a reasonable assertion? Reasonable minds can disagree, right? If that's the case, then maybe that leads to the next question is, why are these white people poor? If there are all these ladders to opportunity, why are these white people poor? And this kind of gets back to your comment as well, Becca. Is it possible that relatively, comparatively, childhood trauma, ACEs, is more strongly associated with white poverty than it is for marginalized racial and ethnic groups? Because a lot of the variance in poverty for Black, Hispanic, whatever, a greater proportion of their variance is already explained by structural factors, such that there's less variance left over for these other kinds of childhood experiences to explain why they're poor. So it's a reverse. It's asking us instead of asking why do ACEs lead to poverty, like it's sort of like, how does poverty lead to why are these people poor, and how does that then lead to their differential responses on an ACE survey? I don't know if that made sense at all. It's paradoxical, not easy to describe, but it's intriguing to me. Alvin, was I like way off base in terms of where you were going?
No.
Okay, cool. So some other ideas just real quickly. I typically get this, I didn't get this today, but like, oh, subjective experience. Well, maybe people perceive their experiences differently and they respond differently on a survey. I buy that. We try to rule that out to some degree. Like, so for example, we don't ask people, were you physically abused? We ask them something more concrete, more tangible, like, were you ever hit, beat, kicked, slapped, punched, which is a little bit less of a subjective experience. But we also ask a question about mental health. Did you ever grow up in a household where a caregiver was depressed or mentally ill? That's a little bit more subjective, and that could vary across different population groups. Second thing to consider, true population differences. Look at rates of depression, look at rates of, not relative rates, but absolute rates of divorce and separation. You'll see higher rates among non-Hispanic white people. So that's possibly part of the equation there in terms of what it is that we're measuring with those 10 ACEs. Lots of things we're not measuring. Those are the 10 things that we measure. There's lots of omitted variables, lots of ACEs we already talked about, and there's also possible other confounding demographic influences. I'll just give you one example. Many of the household dysfunction items that are asked in an ACE survey ask you, did you ever grow up in a household where a caregiver had X, Y, or Z, had a substance use problem, what have you. Well, if you grow up in a household with multiple caregivers, naturally, you're going to have a greater probability of having been exposed, because there's just more caregivers that you could have been exposed to than someone who did not, right? So there are these kinds of things to tease out that if you really want to nerd out on stuff. Okay, so some economic outcomes. Alluded to these earlier. Again, with thinking through the lens of disparities, despite receiving less attention, the available evidence does indicate that ACEs are associated with economic hardship later in life. We recently looked at the AdHealth data set, and surprisingly, perhaps to some, we found that the associations between ACEs and both educational attainment and economic hardship were stronger for white adults than both Asian and Black adults, particularly robust differences between white and Asian adults. Don't have time today just to get into the potential whys of things, but maybe that's something you could be speculating about in your mind, and I could take a question about it. Disparities in birth outcomes. Again, looking at the FACT study, we applied a common theory to try to explain disparities in birth outcomes. You all probably know that in the United States, we have persistent disparities in birth outcomes by race and ethnicity. These have been documented in the United States for 100 years, and sadly, they have not improved. And people want to know why. So one of the most common theories is the life course model, Lewin Halpin's life course model, which basically speculates that it's born out of two main processes. One is exposure to really early life course adversity, and the second is exposure to cumulative stress, the buildup of stress throughout the life course. So we thought we could at least do a loose test of this hypothesis with our study, because we measure not only ACEs, but also adverse adult experiences. So we looked at data that we had available to us. These are again, women who had received home visiting services, and we were able to confirm, yes, there were the disparities that we see in other studies, such that Black women were at a significantly elevated risk of poor birth outcomes like pregnancy loss, preterm birth, and low birth weight. However, once we tested out this model with the data that we had available to us, we looked at 25 different adversities over the life course. We found that those adversities were more strongly associated with poor birth outcomes among white and Hispanic participants than Black participants, suggesting perhaps that those disparities that we see are not the byproduct of proximal adversities, that potentially they may be born more so out of structural and even historical conditions. Any quick questions, please?
Yeah, I'm just curious, the adverse experience we're all measured, some could have happened like during the pregnancy and some could have happened before.
Yeah, so here's
like isolate like the during pregnancy.
Yeah, huge limitation of our study. We did not capture in utero exposure specifically, which is it really is genuinely a major limitation of the study, because we would predict that adversity stress during that period of time would have an outsized effect on outcome. Great question. Other question? Okay, cool. If not, home stretch, home team. How are we doing? Checking in. Are you with me? You're not with me, you're against me. Let's do it. So what can we do about this? I don't about these ACEs. What can we do to prevent them? Reduce their likelihood, mitigate their consequences. I don't know the answer to that, but I'm gonna throw out some ideas for you to consider, more conceptual in nature than empirical. But first of all, we know that there's a raft of economic support programs that we have in our society that have been studied and looked at their effects on things that are similar to ACEs. We know very little about the effects of these types of programs like EITC, TANF, childcare subsidies on ACEs in aggregate. And that's a call to any of you who might be interested in such things. Please do that research. There have been plenty of studies, well, some studies that have looked at the effects of these economic support programs on child abuse and neglect specifically. Effects seem to be modest on average. Don't know why necessarily, but one hypothesis is that the effects may not be as robust as we think they might be, because many qualifying households don't actually receive the targeted intervention. People who are eligible for these benefits don't always receive them. And in fact, a really high proportion, unfortunately, of people who are eligible do not often receive them. An intriguing project in Michigan, you all may know Katie McGuire-Jack. She just did a project where they've been trying to increase the uptake of EITC through using home visitors and they found some promising results there. That's kind of cool. Second caveat with these programs has to do with the idea that if we're interested in preventing ACEs writ large at a population level, we may not get all the way there with targeted interventions like economic support programs. So this roses prevention paradox, you may have heard of this before. Here's what it essentially means. It's a paradox, not easy to understand, but you'll get it. A large number of people at a small risk may produce more cases of a disease than a small number of people at high risk. So good to have an example like Down syndrome. We know that maternal age is strongly associated with the risk of Down syndrome, right? But if you look at the distribution of Down syndrome in society, you'll see that the total number of cases among children who are born to women under the age of 30 eclipses the number of cases to children who are born to women over the age of 45. Why? Because there's so many more children born to women under the age of 30. So it's just a numbers game. Analogous thing here. Children from low income backgrounds, we know, are at an elevated risk of child maltreatment and other ACEs. But in aggregate, we look at population as whole, more ACEs actually occur in middle and high income contexts than low income contexts because there's just so many more families in those contexts. I don't want to get into what the actual true poverty rate is in this room. I'm sure there's lots of battles here, but let's say it was around 13%. That would mean 87% is in the other bucket. There's just a lot more of them. Ergo, there's just a lot more ACEs in that larger bucket. Implication being, number one, we may miss out on opportunities to maximize our prevention potential if we only look at the tail end of the distribution. Number two, arguably, I would say that we need to complement targeted economic supports with other strategies that can reach broader populations, but that can also tap into other mechanisms of effect that can lead to prevention, such as early childhood interventions. It's a broad category of interventions that aim to reach typically families with young children. These are typically family-focused types of intervention models. We know from really good economic research conducted by James Heckman, he's been sort of the leader in this area. We know that through an ROI lens, that these early childhood interventions writ large are not only effective, they also tend to be cost effective. And they pay off more, as this Heckman curve shows, more so than a dollar spent later on in the life course, such that typically programs that are targeted to the earliest years will pay off on average, if they're good programs, $3 to $7 for every dollar invested, very loosely, as compared to, say, a job training program later in the life course where you're lucky to get a dollar back for every dollar invested. Now, this is just one lens. There are many other ways to look at where we should put our dollars. An ROI lens is just one lens. But in terms of human capital, at least, this would suggest that we get paid back as a society when we intervene early, and particularly, again, when we do so through a two-generation lens where we're working with families and not just children alone. Please, Alejandra.
No, just thinking through, I was just, I think that these like early childhood programs, like early childhood education, are you thinking that they would help prevent children's experiences of ACEs, or they would buffer the effects?
Both.
Okay.
Yeah, both and. Both ends. It's very plausible I would think that if you are working with the family, again, within a 2-generation context, right? Not just like child goes off to school.
Just sending kids to preschool.
Yeah. So some of the best like center-based preschool programs that have been studied, they don't often get implemented in the real world, but the ones that have been really studied a lot were really enriched with family involvement components or what have you. So
Do you know if they've looked at ACEs? I don't know if they can, but like
Yeah.
Perry Preschool has looked at like ACEs as an outcome.
I don't know if Perry Preschool has, the Chicago Longitudinal Study has. Yeah, so great questions. So real briefly, mentioned home visiting before. You all may be familiar with these types of models. Loosely, they provide support, education, and resources to pregnant women and families with young children. Most of them employ trained professionals, such as public health nurses, social workers. Some use paraprofessionals. Their general aims are to promote maternal and child health, enhance parenting practices, increase household stability, and prevent child maltreatment. And the federal government has invested a lot of money in these programs. The McVie program this year will allocate about $600 million to support evidence-based home visiting programs, such as those that I mentioned before here in Wisconsin with the Family Foundation's home visiting program. So there certainly is some evidence to support these models. They can do a lot of things. That being said, there are some challenges to these models through a prevention lens. Again, if we're interested in preventing ACEs at large in the population. Number one, many families don't accept these services, right? And many families who do accept services drop out early. Number two, effect sizes are a little bit disappointing, particularly given the duration and intensity of these programs. These are long-term programs. The effect sizes tend to be heterogeneous and small on average. Thirdly, again, going back to the prevention paradox, services that are targeted to priority populations like low-income populations, they may not generate as much total impact because you're not reaching everyone who is at risk of ACEs. Lastly, again, these programs tend to begin prenatally, last for multiple years postpartum. They're pretty costly programs. They average about $10,000 a year per family on average, which presents a huge scale-up problem, right? So we reach in Wisconsin with the Family Foundation's program roughly about 2% of newborns, right? So we have this robust statewide program. We're getting to 2% of the newborns that we could reach, in part because these programs are costly. So an alternative approach that I want to pitch to you today is to think about targeted universal strategies for serving families. So targeted universalism goes by different names: progressive universalism, targeting within universalism. It's a pretty simple idea though, right? It's a prevention strategy. It tries to impact a broad population while at the same time allowing for flexibility in how services are targeted or tailored to different populations. So you're reaching a broad population, but it's not one size fits all. Not everyone gets necessarily the same thing. So you're balancing equality of access with equity of resource distribution, whereas other approaches may do it equity on both sides of the ledger, equity of targeting and equity of resource distribution. The aim here is to provide individuals, families, and groups with the types and levels of support they need, no more, no less. It's an efficiency argument. One example in the home visiting space is a model that was developed in North Carolina by Ken Dodge. You all may have heard of him. He's like on my Mount Rushmore of, I'm not on his, but he's on my Mount Rushmore of social scientists. He developed this really cool model called Family Connects. It's a low-cost universal home visiting program that varies the dosage of home visiting by family need. In brief, it begins with hospital recruitment because that's an easy way to reach families at a really crucial time in the life course. They then enroll families, ask them if they want to receive a home visit. They get really high rates of participation. And then the home visitor goes out, does a comprehensive family assessment. While doing those questions, provides some supportive guidance, has a conversation with the families about different things, uses motivational interviewing and motivational enhancement techniques to increase the likelihood that if the family needs additional resources, they may agree to take up those resources that are offered to the home visitor. The home visitor can also come back and do additional home visits as needed, but not everyone gets the same thing. Their RCT, they found a bunch of different benefits. They found just with reduced ER visits alone, a 3-to-1 ROI with that study. Now, we actually conducted our own replication study here in Racine County. We use a natural experimental design in Racine County. And sadly, we did not replicate the effects. Guess what? That happens more often than the opposite, actually. Independent replication trials, quite typically, not just in home visiting, but writ large in the intervention space, they often fail upon replication. So nevertheless, our partners in Racine County have continued to do this work. They've used those lessons, learned from that, and they're continuing. They've now shifted over to a slightly different model, but it shares a lot of the same commonalities with the Families Connect program. I'm not going to go through this in detail. You'll have access to the slides. A couple things though I want you to know about it, just some data points. This program reaches well over 300 families per year in Racine County. Racine County also has a long-term home visiting model called Healthy Families America, which is a very widely disseminated home visiting model. Their Hello Baby program is able to reach 10 times more families than their long-term home visiting program. That's not to say that's the only metric you should be considering in terms of what we should invest in, but it is an important consideration, actually reaching families. Arguably, if you want to have an impact on at a population level, it's important how many people you actually reach. Also, the other concern, a lot of people are concerned, well, if we go universal, are we going to really benefit those families who might need those supports the most? I don't know, not always, certainly not always, but in this case, you can see that more than 70% of the families that receive these home visits earn less than $75,000 a year, and roughly 37% earn less than $25,000 a year. And about 30% of the women served are Hispanic, 25% are Black, both of which exceed county-wide averages among the birthing population. A second example, and I'll just go through this briefly, and we'll just have to leave off some of the data points probably, but I did want to mention family resource centers as a second example of targeted universalism. So for those of you all who don't know, which I'm assuming is most of you, these family resource centers, again, are community hubs. There's about like 60 of them distributed throughout Wisconsin. Nobody knows about them, unfortunately. And they offer an array of services and resources that aim broadly to strengthen families, enhance parent-child interaction, and promote child development. There's about 3,000 of these distributed across the United States. They serve upwards of 2 million families. So there's a lot of capacity that exists within these family resource centers. They vary to a great degree by design, because these are community hubs that are supposed to reflect the needs of the community. So there's a joke in this field that once you've seen one family resource center, you've seen one family resource center. They all vary, they all are special snowflakes, which makes it miserable for evaluators to study. And it's in part why they've really never been studied in any rigorous kind of impact trial. There's other reasons as well, like it's impossible to randomize, et cetera. So I would argue that, like Hello Baby, these FRCs do have considerable primary prevention potential for a few reasons. Number one, they offer services and resources that can be plausibly linked to the reduction of ACEs. They provide economic supports to families. They engage families in parent-child interaction activities. They provide parent education types of programming, et cetera. And they also link families to services and resources in the community. Again, they're flexible models that could be tailored to meet the different needs of different families and communities. And again, very importantly, they reach large numbers of families from all socioeconomic backgrounds. Subnote, I also think it's important to consider who's willing to engage in services. You can make, I think, a very fair argument that voluntary universal programs like this are more likely to be received well in some communities than programs that are mandated or targeted, which can sometimes produce stigma within families. So we launched a study in 2021, and I'll wrap up here soon, I promise, called the Strong and Stable Family Study. This is sort of a first of its kind study of these family resource centers with two broad aims: to identify protective factors that reduce the risk of child abuse and neglect, and that explore the impact of these FRCs. We're doing qualitative focus groups and interviews with program staff and service recipients. Big shout out to Anna Walter, who's done yeoman work on this project on the qualitative side of things. Thank you, Anna. Presented some of our first findings yesterday. And then we're also on the quantitative side of things. We have this longitudinal design, a matched comparison group design, where we gathered baseline survey data from 2,135 families, a third of whom received services from a family resource center. And now we had this intentional design. We gathered data from a much larger sample of the general population because we knew the general population would look a little bit different than families who received the FRCs. And so now we used a matched comparison design using propensity score matching to identify a subgroup of the general population who look a lot more like those FRC families. And now we're doing follow-up data collection, and we're going to be linking child welfare records and using some propensity score weighting to sort of equalize them out. This is a quasi-experimental design. Is it the most rigorous design that you could come up with? Probably not. But as I like to say, in the land of the blind, the one-eyed man is king. There hasn't been a more rigorous one than this. So I'm hoping that this will be at least a start of something. I'll just end on a couple of notes, and then I'll take a question or two before we go. This is the sample that we're looking at. I'll just highlight briefly that FRCs our FRC sample reflecting what families are served. We work with 18 different FRCs. You can see they serve a much more racially and ethnically diverse population than you'll find in the general Wisconsin population. You'll also see that they're more economically disadvantaged on average than the general population, which is not surprising. But again, not everyone who receives these services are poor. In fact, nearly 20% reported earning $100,000 or more of household income, which is decidedly non-poor. Couple other quick things. I do want to get to these. A couple nuggets. Can you give me two more minutes? 2 more minutes. All right. So we asked a whole bunch of questions at baseline about their economic insecurity. Real briefly, you can see that the FRC sample was far more likely to report these various social determinants of health, unemployment, being evicted, homelessness, etc. I want to skip though. Here are some of the different types of services they receive. I just want to skip real quickly to this last thing. Some pre-post comparisons that we run. These are very preliminary, so don't take it too seriously. Don't be too harsh on me. We found some interesting findings recently, and that might make some sense to you. So we asked them a question at baseline, and then again 3 years later in our post-baseline survey, a couple of items. I have trouble affording what I need each month, often or almost always. We see that in our FRC sample, 16.1% of our families who received FRC services said often or almost always they have trouble affording what they need at wave 1. 3 years later, so wave 1 was 2021 to 2023. Wave 2 is like right now. You see that it's about the same, has not improved really, 16.8%. So actually a slight increase in them not being able to afford what they need each month, which is a little disappointing. Here's the general population. 7.7% thus far. We haven't completed the data collection. 7.7% of our general population sample endorsed that item, that they almost always or often have trouble affording what they need each month. That rose to 13.8% three years later. Similar things for food insecurity, similar pattern where we see higher rates of food insecurity at wave 2 than wave 1 for the FRC sample, but an even bigger gap emerging in the general population sample. I don't think, my guess is I'm going to just stop there. I'd love to get an interpretation of why we're seeing that. Why is it that we're seeing things getting worse if you buy these data points, if you buy them, and we're matching these people over time? What's going on? Inflation. What's going on economically in society? This isn't, come on, help me out. What's going on? This isn't rocket science. What?
Mass layoffs.
Let's keep on going. Keep going. What else? Housing. Loss of COVID benefits. Right? So I don't know. There's a story here, it seems like to me. I don't want to just like accept the first idea that comes to mind, but it seems to tell a pretty compelling story of the impact of macroeconomic changes in our society. And I don't know, speculatively, very speculatively, it's possible that there's two interpretations of why the FRC sample isn't faring quite as poorly as a general population sample. One very reasonable hypothesis is that we have some floor effects. They're already more economically disadvantaged and they don't have as far down to go. I buy that. The more optimistic portrayal is maybe FRC support and resources help to buffer them to some degree, the resources, those, again, it's an optimistic portrayal of the data, but that's where I am. Let me go ahead and stop there. I could keep going, but it's time.
All right, join me in thanking Josh for tonight.